I'm chairing a panel discussion, and I think the answers it kind of fits into what Dr. Okello with single L has just talked about. We're talking about the roles of the different partnerships. And good enough, I thought all the partnerships were from north to south, but we also have the south-south. So CANESCA is well represented, Dr. Okello. So for this panel, let me have Dr. Claire Baaka, who is a fellow in critical care medicine. And she'll be telling us more about her experience. I will also have Dr. Cornelius Sendagire, who is also a fellow. In case you didn't know, he will tell us more about his fellowship. I also have Dr. Philo Nambooze. See, most of us always, after our names, we put MDCHB, MED, brackets anesthesia, and then after that we put FCA, brackets EXA. She's welcome to the club. Most of us do not have to work for it though. And then to replace Associate Professor Arturo Quizera, we shall have, I think he's also soon to be Associate Professor, Andrew Chintu. When Chintu completes the panel, then we shall start discussing. I think I'll start with the... Cornel, don't scare me. How many of us have heard about scale? Apart from the ground rounds and the discussions we've had, on that group. Dr. Chintu, or Associate Professor Chintu, just tell us about scale. What is it about? Because honestly, I might not know what scale is in full. What is scale about?
Is it morning? Good afternoon. So scale, I'm sure most of you are surprised I'm talking about scale, but scale is something that actually happened in the meetings. I think we started them in 2021, 2020, and it's about strengthening health workforce capacity through global learning. So for the people who don't know what scale means, that's what it means. So these initial meetings actually started from the office of the Dean, Makerere University, for the people who don't know actually how it started. So we started by trying to see that how can we develop subspecialty trainings and all that. And if we all know that our Dean, the Dean for Makerere, has a great root from Cambridge. So she had her collaborations together with people like JP Bagala. So they initiated something and the discussion started from there to see how best we can improve on the specialty trainings in Uganda, which had actually to do with things like not just critical care, but had other things like obstetrics, neonatology, anesthesia, and other things. So, so the initial meetings, basically they had to first look at and find out how good is the program in Uganda. Can we get people to go to the UK and safely practice? So some of the things were they actually reviewed the UK, the Royal College of Anesthetists and other things, looked at our curriculum, and they actually thought that our training was actually adequate. So the other discussions that came in place were like, do we get the people to come from the UK and train the people here locally, which were called the volunteers? These were mainly going to be clinical people and all that. Or we try to do the distance learning platform where you get people from Uganda and go the other side. And then the low-hanging fruit then, I think the departments that were willing to initiate that were critical care, but other specialties came along. That's why you see we have neonatology, we have things to do with obs and gyn and all that, and other things will be coming on. I think for now I'll stop there.
Thank you very much. Dr. Sendagire, I think the other thing that we don't understand on the list of the partnerships that we've seen on that list is CHESA. What is CHESA?
Thank you very much. Good morning, everyone. So CHESA is a Center for Health Equity in Anesthesia and Surgery, or in surgery and anesthesia, sorry. Anesthesia usually comes before surgery, but somehow, yeah. So it's a global health initiative that was started by merging the Anesthesia Global Health Division at UCSF with the Global Surgery Division. And both those divisions have had strong collaborations within the Global South, even before the CHESA was formed. So it was formed out of the foundation that other partnering institutions from the Global South that have been working together with the University of California, San Francisco, decided to come together to try and increase safe surgery globally. And as you know from the previous talks that we've had this morning, we have talked a lot about access to surgery, access to anesthesia, access to safety in anesthesia and surgery. And of course, that safety always starts from the anesthesia side, because we are then supposed to establish that these patients are going to undergo a safe operation under safe circumstances, and they are safe enough to undergo that operation. So because we have significant limitations in the Global South, not just in terms of numbers, but as well in terms of the quality of the providers, because for those of you who may not know, an anesthesia provider can be labeled as anyone who gives ketamine. Okay, so this Global Health Initiative while it's founded in UCSF, it includes institutions from, for example, Uganda, Makerere University, the Association of Anesthesiologists of Uganda are all part of this CHESA Global Health Initiative to try and increase access. So CHESA, one of the visions or one of the goals of CHESA is actually increasing access to safe perioperative care globally. And when we say globally and we think of Global South and Global North, we forget that even within the Global North, there are settings that are similar to ours here in Uganda. And there are settings here in Uganda that are quite as advanced as settings in the Global North. So that's why CHESA chose to make itself more global, in the sense that even within the United States, there are some hospitals that are quite similar in terms of safety or being unsafe as some settings that we have in Uganda. So that's the whole idea that lies within CHESA. And through CHESA, we've been able to have multiple fellows from all over the world, not just the Global South, but from the Global North, and have collaborations where fellows from, let's say, Uganda would get experience in a high-income setting to understand the systems there, as well as the other way around, where fellows from the Global North come to countries like Uganda, and they go to various countries as well, from West Africa, Southern Africa to Eastern Africa, and they get experience in these settings to understand what are the challenges, what are the limitations, how can we make our setting better based on the experiences that we've accumulated. So that, because we live in a global village now, it needs to be that we actually work together to improve the access to most of our patients. Thank you.
Thank you very much, Dr. Cornell. The president himself has just spoken about CANESCA. So you know about CANESCA. And amidst us, we have Dr. Philo Nambooze, MBCHB, MED, Anesthesia, FCA, EXA. Dr. Nambooze, is it necessary to have that extension? Is it relevant?
Good morning, ladies and gentlemen. It certainly has a good ring to it, you have to admit. I am Philo Nambooze, and I'm honored to have the president himself having explained to you a lot about CANESCA, because it has been the question, what do you benefit from CANESCA? What does it add to your qualification? And I think for me, considering CANESCA was, I had limitation traveling, like Drs. Chinto, Cornell, traveling to the upper north. So you find that CANESCA gave the opportunity and benefit to have an international experience and relationship to people beyond Uganda, while staying in the setting close and around home. So that was the main benefit for me going into it. But what are some of the benefits that you can get out of CANESCA? So I'll start with some of the members. In CANESCA, there are members that join CANESCA as the foundation members. I'm sure most of the faculty and the people you see here, Dr. Kateregga being one of them.
We didn't have to suffer like you.
They joined as foundation members when it was starting out. So I think that was, you had your qualifications, they were from a university and institution that was well known, so you went in as a foundation member. And part of requirement for that foundation member was that you had to pay the subscription fees for it. So still some people missed out because they did not what? They did not fulfill that requirement. Then we get the honorary members, the ones who go in because you're honored, you have the qualifications, you've excelled in the field of anesthesia in your setting, they give you that one. That one I think most of us are still working towards. Then the other type of fellows is the one where you do the work. You do the work, you do the examinations that are spanning over all the member countries in CANESCA. And then if you do pass the exams, you become a fellow. Case in point, I am sitting here today. Among the benefits of CANESCA is that when you get the qualification, it is spanning over countries beyond Uganda. Like the president said, there are very many state countries that have come on board, Somalia being the latest. So your qualification is recognized in all those member countries. Then that goes with the networking opportunities, and then it goes with the continued professional development. And among the continued professional development we are talking about today is the conference we are going to after this one. So this month we are having this one, next month, November 19th to 21st, let's all prepare to go to Kenya. It's the closest you can get to attending this CANESCA conference, isn't it? So the first one was in Zimbabwe, that's where we graduated as the fellows. Last year it was in Malawi. So really, really Kenya is next door. You do not need a passport to get into Kenya. We need to go. That's the next. Then they have the e-learning module that they've set up. The e-learning module has come more recently, because I think that was the challenge that we had, that you kept having to communicate to get the learning materials. They've always had the modules. It's just that before it was connected to the DEXA, the one that was used from one of the funders. So the e-learning modules, they are calling for authors to come on board. So all the faculty, the qualified people, you can come in as e-learning authors for that. And among them, we have Dr. Mary J. and Dr. Ocheng Paul, who have so far signed up for it. So we need more people for that. On this e-learning module, when you do pay, among the membership, I took the fellows, so there is also membership. Anyone training for the postgraduate, if you're doing your postgraduate training, you can apply as an associate member. And for those who are done with their postgraduate, you can also apply as a member. Like we said, you need to pay the subscription fees for you to be activated and you access all these things. So that's all it requires, pay the subscription. You can access the free research methodology courses on it. You can access all these capacity building things that are on it. And you access so many articles, journals, free learning materials on their platforms. I don't know if that answers you.
Thank you very much, Dr. Philo. Dr. Claire, don't think I forgot about you. So back to scale. You just tell us about your experience for your fellowship, really, and what does it take? Is there something special that you did to qualify for? Because I'm very sure all of us would like to go and, scale up. Thank you.
Right. Thank you, Dr. Kateregga. To answer the first question, my experience. Basically, this is a 2-year fellowship, and it's the placement is in the UK. I was particularly at Cambridge University Hospital, Addenbrooke's Hospital, and I had quite for the 2 years there's extensive clinical practice. At the same time you're having lots of tutorials and stuff, so it's quite intense, but so there's a lot of learning and skills acquisition. So that was really different, because if you've worked in Uganda and then you go to a first world country, things are a bit different and you have to scale up. To them. But they were quite supportive. The program has been set up to support both people from Uganda, and also it's an exchange program. For example, there are also people coming from the UK to have their experience here in Uganda. So it's quite supported, and definitely when you come back, there's so much that you have learned, and there's so much contribution to the critical care setting in particular. Like Dr. Chinto mentioned, there's also neonatology, emergency medicine, fetal maternal medicine. So but focusing on critical care, there's a lot that I learned, and I came back, and I believe from my mentors I'm definitely different from So the process is definitely a bit complex from when you get to apply for the placement in the UK, going through all that English examination process and finding accommodation in the UK. So it's quite a process, but again, well supported. Now, our second question was, I don't remember. What was the second question, Dr. George? Apart from my experience.
What are the special requirements that you had? So you must have completed, for example, your MEd program for those who are doing anesthesia and critical care. And currently, it would be important that you also work in, government institution. And that's important because then when you come back, you can contribute to the public. This is UK-Uganda partnership with the basically MOH and NHS England. So that's the other thing. You have to have at least been in a government setting. And you have to take part in the virtual the virtual round sessions that we have monthly. The next one is going to be on the 23rd October. So take part. There's a lot of discussions in critical care that you can, either chair or present. So that's the other thing. And show your interest. We have the scale mentors
Dr. Cornelius is one of them, and you can always approach them to give you more details on the process and what needs to be done. And we are here to support those who would like to be fellows. Thank you.
Dr. Claire, you're trying to scare the people from going. But Dr. Cornell, what are some of the challenges that you faced? You know, I'm just feeding into Dr. Claire's experience. She describes a fast-moving, economy and, setting, and then you have to come back home. What were some of the challenges that you faced after your experience in the north and you come back to the south?
All right, thank you very much. That is a loaded question, but I think sometimes you have to be candid about the experience. And I've had this conversation with so many fellows who go out of a low-income setting into a high-income setting. And there's always need to be understanding of what the expectations on the other side are. The moment you leave this country, no matter how good you are, no matter how excellent you are, no matter how many procedures you've done, it does not matter once you arrive there. The assumption is you have no idea. Okay? And this is why it's important that we start a program here in Uganda that allows us to train our own fellows and grow the field. And through training our own fellows to grow the field, because they're going to get hands-on, you're not going to be undermined. We know which level you are. I think it's easier to learn when you're here. You have the caseload. The difference between us and the high-income setting is systems. They have a lot more efficiency. They have reduced loss in terms of resources. Even when they have a lot of resources, they really know how to use those resources to achieve the best outcomes, which we don't have. We lose a lot with even the little resources that we have. But you always have to remember that once you get to that aeroplane and you leave the country, you have to leave all your preconceived ideas that you know a lot. And when you arrive there, you have to be a learner all over again. When someone asks you, have you ever placed a central line? You probably want to say, I've placed a few, I would like to learn. Do not say, yeah, I have. This is simple stuff. Don't say that, okay? So what I'm telling you is what people have experienced, because when you come off as someone who is not teachable, they are not going to teach you. Because the first thing you're going to feel is, even if it is somewhat subtle, is always going to be a tinge of racism. Always. And you sort of try to understand where the other teams are coming from. This is a relationship that needs to be built. And when you feel the tinge of racism, perhaps it's okay for someone to not be sure what you're capable of, because they have not trained you, they do not know your training system, they don't know your curriculum, they hope you know, but they're also very scared in those countries of litigation. So they are very cautious, but you'll tend to find that the racism is more abundant among the less trained than among the more trained, which is quite interesting. The less trained someone is, they tend to undermine you even more, while those who are more trained, they tend to expect a lot from you and try to draw it out of you. And not everyone is going to be like that. That's the other interesting thing about fellowship training. You'll find some who really like you and believe that you can achieve a lot, and then you have some who don't like you. And sometimes I listen to some of my own students and fellows, and they talk about, how life is hard. Try doing a fellowship. You're going to find out how hard life is. It gets really hard because you are all alone, that side. You have no one to, except the guys in Uganda. Now, if you're in a country that is 8 hours behind Uganda, Ugandans are sleeping, you are awake. You have no one to talk to. You are awake, Ugandans are sleeping, Ugandans are awake, and they're chatting away. Okay, you wake up to text messages coming in, but you have to go to work, you have no time to respond to them. It's most of us in the first 3 months, first 3 to 6 months, it's really a battle of creating rapport, relationship, building trust in those who believe in you, and winning the favor of those who don't believe in you. And that is what you're struggling to achieve in the first 3 to 6 months. Usually by the end of 3 months, you've sort of built enough rapport for people to trust what you can do. And then they start to think that they actually taught you all these things that you know, and it's a very humbling experience. And this I keep telling the students who I interact with and those that I mentor, that to be a learner, you have to be humble. You have to forget everything you think you knew. You have to do it the way they do it. You don't, in Uganda they call it ugezi-gezi. You do not bring your how do you translate to what? Luge. You don't want it to come off that you are not teachable. So that means that you have to express humility, and regardless, in Uganda, if you've been the master at incubation and you go there, you find they're doing it slightly different. Some of us here, we select our endotracheal tubes before we intubate, right? There are some situations where you look in and they tell you which tube do you want. And you're not used to that. And there's a way you usually do your thing. And you're supposed to do it, when in Rome, do as the Romans. And there's some things you're going to learn that you should say, this stuff, I'm not going to take it back to Uganda. Okay? And some things you learn and you say, I've learned how to do it the way they do it, but I would never do this in Uganda, because this is not the right thing, in my opinion. But you don't express that opinion to them that this is not the right thing. You just keep it to yourself, okay? Be introspective. Talk to people back home. Let them encourage you. You can go through it. Claire knows. So, so that is the bit about, so do not be fooled. And when I hear the hardships of training, you have no idea what a fellowship does. Most of these guys come back and they're experts, but they're not just experts in technical skills. They have mastered the art of non-technical skills as well. How do you deal with someone who does not like you? How do you deal with someone who wants to see your downfall? I think the first time I went there, I'll just give you a snippet. The first time I went there, I had never put an endotracheal tube in the esophagus in more than 2-3 years. But my first intubation, everyone is watching you, okay? And they're waiting to see this African is about to intubate. Oh my God, what's going to happen to this patient? So, and it went into the esophagus. I couldn't believe it. Even I couldn't believe it. The odd thing is, they only give you one chance. You have one chance to put that tube in. In Uganda, I was a god. And all of a sudden, I am a first-year resident in anesthesia who has never intubated a patient. So you have to be, and it's humbling. And part of learning is understanding that there is still more to learn, and it's okay. And I think one of the most beautiful things I enjoyed about fellowship training is that all of a sudden I was not primarily responsible for these patients' outcomes, and now I had the freedom to learn as much as I could in that situation, to just forget everything that I thought I knew and see how do they hold the laryngoscope, how do they hold the endotracheal tube, how do they do this differently, that's what I was interested in. How can I do my art differently when I go back home? I don't want to impose what I already know. I just put it aside. When I come back to Uganda, I merge everything that I've learned with what I knew before, and I'm different, okay? So For those of you who think that, oh, it's such a prestigious thing to go do a fellowship, oh my God, you've flown in a plane and it's so glorious, and when we come back here, we are awesome people. Trust me, everyone, let no one deceive you. Let no one deceive you. It is gruesome in the first 3 months. I have a lot to say about it. I think Claire has a lot to say about it. I think everyone has a lot to say about it. But do not be fooled. It is not you land and you're already doing stuff. No. It is a process of building trust, building rapport, and being very humble and willing to learn. And that makes you a lot better than when you left. So for those of you who are about to go, hang in there.
Like you said, you live here as a god. The spinal refused. It refused. So, but what I take from the experiences and everything is the exchange. There's so much good you get. Of course, and another thing that came through Dr. Okello's presentation is, yes, we should grow. The partnership should help us grow so that we can help our local people better. So I think these people are all, better. What the challenger is actually looking for is, what he has not said is, the way they do things and their setting is totally different, that you come back here and you don't even have some of the tools, okay, to do what you have actually learned. So you have to go back to, to the old way of doing things because some of the equipment is not available for you. Dr. Chintu. Oh, Associate Professor Toby. How best can we, how can we increase our benefits from these partnerships? How can we get the most out of them so that, despite the fact that we go and suffer, though some people think, Dr. Cornelius, they look at you and they're like, that guy, he went to the US. They have no idea. How can we best benefit from these partnerships, Dr. Chintu?
Thank you very much. Well, I didn't suffer like these guys. So the question is, how do we benefit, right? Or best benefit. So maybe from experience, one of the things that I've learned when you're given an opportunity, which I believe even the Cornelius will believe, is that when you go out there, this is the talk I had, remember you're representing a country where you're coming from. So some of the questions I actually also got, I'll give you my first scenario. There's what they call, if the people went to Canada, there's what they call the pre-entry assessment program. So basically, you don't start the fellowship until you go through all that, and then they are sure that you're fit to practice in their own country. And when you fail, you can never go anywhere else in Canada. So the first thing they gave me was a neonate, because my supervisor was both a pediatric and obstetric anesthesiologist. So they gave me a neonate, and everyone in the room froze. They're all watching. Good enough, I think my Bujagali was on my side. So I succeeded in the very first try. So the first question that actually came, though one of my bosses is, I think, the guy, actually, what made my life easy, there was a guy who was helping the program and was from Haiti. And he also had gone through the same thing, so he had actually briefed and everything. So the first thing they asked, did you have your training from anywhere out of Africa? You know what that means? They don't expect that from you. So the good thing, when they could always ask, this guy could say, it's because you went to the good schools. So back to how we can benefit. So when you go out there, you're there to represent. So try to create more links and ties, because at the end of the day, you need to help others benefit from your skills. Try to create more links. How can we benefit as a country? Is it possible to get also these people to come and even work with us instead of us going the other side? Because it's another way. It's cheaper and everything. Because I'll give you an example. A ticket to Canada for the people who went to the Vancouvers. Now, I mean, isn't it about 7 million? Yeah, but the truth is that it's quite expensive, and people have been given all these fellowship opportunities, but sometimes they're like, we give you an opportunity, but there's no money. It's like they're telling you, basically, don't come. But one of the things that I've learned through all this, when I met all these guys, we created lifetime links. And these people have actually helped us all around, whether in the association and all that when you have issues, and even in terms of learning. For some people, I think you've seen I've been sharing all those CMEs for, I'm not PIDS, but I share a lot of PIDS things because I'm still part of the McMaster group and as part of the PIDS thing because my boss was pediatrics. So those are links that I get, and actually whether I'm going to benefit from them or not, I still share with everyone else. So the thing is that when you're out there, you're watching, how can my friends back home also benefit from whatever I'm doing here? There are people there who actually don't even know what we do. They don't know actually what we do. When they talk to you, they actually get interested in even visiting the country or even helping other things. They can even help in terms of even program teachings. For the people who knew Brian Warrener, I think many people here benefited. It's because when they came around, or people went there, they showed and represented and gave a very good impression. And remember that when you're there, you're actually not just representing yourself, but the entire training program that where you're coming from. So which leaves an impression. If you leave a very bad impression, trust me, it will be very rough for the next person coming. That's if they even let them in. You're hearing what the Cornelius are telling you. It will be rough, my dear. If the person who went there before you was bad, they may not even let you cannulate that patient. And the entire room will be watching you. I don't know if I've said.
Yeah, thank you very much. So I think what is coming through in the discussions that we're having is, yes, for our workforce, training and betterment, we need these partnerships. They are not cheap, of course. So when you have an opportunity to go and represent, you do your best so that you open more doors for the people who are coming after you. For those of us that have not yet or are thinking about, adding some of these, it makes you a better person. It means you can actually serve in a wider kind of, community. And for the residents, what you're facing here is just a tip of the iceberg. You need to first go through a fellowship in a foreign land. And so that's where CANESCA comes in, because it is a training fellowship within your region. One other thing that these people did not talk about is the food. Food, you guys. You are used to your kalo, you are used to your matoke, then you end up in Trump land. A plate of food is like $100 or something. Not burgers, food. So you're going to be sidelined to Rolex, because they are kind of Rolex. So burgers, you come back and we cannot recognize you anymore. But for in other settings, the food it's too hot, let's say. You're not used to, and everything they put, even when you buy pancakes on the street, they are hot. So the food, the social thing is different. So with CANESCA or with our trainings, so the people who did PATA, the people who are doing, regional fellowships, the Brunos, you're having it easy, okay? So the partnerships are necessary. They improve us to grow better. Unless the audience has more questions for my panel, I think we have answered all our questions. Questions? If there are no questions, thank you very much. Yes.
Maybe just like Cornelius has said about humbling and knowing who you are when you get there. I've just remembered the story. So, the way the residents here say I was late, traffic and all that. So I actually went. Being an African, I'd never seen snow. And it was extremely cold. So we had a list because the theater list used to start at 6:30. So ideally, the latest time you should be inside there is 6. You get it? So I actually got there at 6:15. There's an old man, I remember him very well. He sat me down and told me, I don't care whether it has snowed and closed off your door. We expect you at work. And he says, I understand where you came from. You are a senior person. You are a lecturer. I was. Here, you're a student. Your boss should never come before you. Many of you here actually come in and walk in, and he says, traffic, I had a meeting with Dr. Cornelius, but you've not even informed. So the gentleman told me, the next time you come back here, whether it is 2 minutes late, we shall buy you an air ticket back to Africa. I remember his words. And the other tricky thing they could also do is, I think the Cornelius know this, what I used to do. When you come in late, you know what I could tell the Cornelius? Is like, go have breakfast. Indirectly, the gentleman has actually chased you away. So it is, but here you tell it to a student and like, Dr. Chint is rude. But it's discipline. Some of you come into the operating theater and you want to work with someone, you don't even know the patient. And you just discover and you want to join. And when the gentleman tells you, please leave, you say, Cornelius is actually rude. But it's called discovery, anesthesia. Thank you very much. So the truth is that you have to be humble. You must remember your roots and you must know where you are. Thank you.
Thank you very much. That sounds it.